Hello and good morning, good afternoon, or good evening, depending on where in the world you're joining us from. My name is Ashley McKim, and I'm Director of Innovation and Improvement at the British Medical Journal. It's a real pleasure to welcome you here to the first in our series of webinars from the International Forum on Quality and Safety in Healthcare. We hope this event will help to fill the gap while we wait to reschedule the physical India Forum. 2020 has been a challenging year, and never before has healthcare played such an important role in global events. As COVID-19 continues to put a strain on healthcare organisations and staff in every country, quality and safety of healthcare has never been more important. Thank you for taking time out of your schedules today, and thank you for all the amazing work you've been doing over the last few months during the pandemic. We're all truly indebted to your service. Over the next 90 minutes, we're going to be hearing from 4 fantastic speakers, which we hope will provide valuable learning. To make this webinar as effective and as efficient as possible, only our speakers can turn on their webcams and audio, but we still want you to contribute. Throughout the presentation today, please type your questions in the Q&A box, which you'll see at the bottom of your screen. If you spot a question from someone else who you think is important, please give it a thumbs up and we'll be more likely to ask that at the end. If you've got general comments or technical questions, you can pop those in the chat box, which you'll also find as a button at the bottom. Before we start with our first speaker today, we've got a quick poll to get you interacting. So on the screen, you should see 2 questions, one about your discipline, your role, and the other about how you feel COVID pandemic has affected patient safety. So please take a minute and click on your answer from those questions, and we'll give you 5 or 10 seconds just to respond to those. And I think just as a reminder today as well, we go through today's webinar, the chat box is great. I've seen some of you already mentioning where you're coming from and your experience so far. So please feel free to introduce yourself, tell us which city or country you're coming from, and please contribute to the commentary as we go through. It'll be great to get you involved. We want to try and make this as interactive as possible. So we'll just give you a minute or 2 more to complete the poll. And then I think whenever the BMJ team are ready to pop up the results, we can have a look at those. Great, so it's really fantastic to see a real mix of people here today. As you know, to improve patient safety, we have to involve everybody from your senior leaders right down to your students. And it's really nice to see a mix of all the different types of people we want to involve in patient safety. And also really pleased to see that we all feel that COVID will increase the focus on patient safety. And I think this is what today's webinar is about. It's what we can learn, what we can take away after COVID, after this pandemic, to improve patient safety for our patients. So we'll continue that discussion, and please add your thoughts and your comments as we go through today. We're going to move on to our first speaker. We've got 4 fantastic speakers today, and our first speaker is one that you probably already know, Federico, who's Vice President and Senior Patient Safety Expert from the Institute for Healthcare Improvement. And Frank's going to talk about what he's an expert in, which is how do we build a culture of safety, and lots of learning that we can take away after COVID. So Frank, over to you.
Thank you, Ashley, and welcome everyone. Good morning, good afternoon, good evening where you are, and I wish you all a good day. It was great to see the results of that poll, how we have people at all layers of the organization, different disciplines. And an important aspect that I saw was how much COVID has caused us to pay more attention to patient safety. And there are a number of you that commented on how it has derailed some of your initiatives. And we're finding that everywhere. And I can understand that resources need to be applied to patient care, and oftentimes our initiatives are put aside for a while. However, all those lessons that you learned in order to prepare and work on those initiatives are lessons that you could be applying during the COVID crisis to innovate and to find ways to better manage patients. Before I go on, I'd like to first congratulate and thank everybody and who have been at the forefront of managing this pandemic. Those of you who are at the point of care, those of you who are providing care for COVID and non-COVID patients, thank you so much for all that you do, for putting yourself out there. Not only are you risking infection of yourself and bringing it home to your family, but you are really providing a service for everyone. And I thank you and recognize you for your contributions in wanting to do that. Before we start, one of the things that I find is really important is that you can adopt any definition that's out there around a culture of safety. In the United States, the Agency for Healthcare Quality Research, AHRQ, has a definition. Other organizations have a definition. But what's most important is, can you, in your own words, say what a culture of safety means to you? Because it is easy to recite what someone else has said, but it becomes really important that to make it your own, you must be able to use your own words. Then it becomes real. Then it becomes something that you can work with, and the values and the shape of the organization helps you be able to make sure that that culture of safety becomes a reality. So a first step is, what does a culture of safety mean to you? And it'd be nice if you chat some of those comments in. Ashley will read them out to me a little bit later, and we can use them as part of our discussion as we go forward. During COVID, we've had a number of innovations that have happened, and they include things like use of iPads and baby monitors for communication, where in the past we might not have thought of using that. Patients that are COVID positive are in isolation. We wanted them to speak with their families. We wanted clinicians to speak with them, so we took advantage of that kind of technology. We broke ground and used the ventilator for 2 patients, so we used anesthesia machines for ventilators. In the United States especially, telemedicine was a very limited use of the application. And because of COVID, and because we want to keep our carers safe, but we also want to keep patients safe and don't want to crowd our emergency rooms, telemedicine had reached a tipping point where now it has become a normal part of care. We looked at, how do we reorganize and minimize the number of times somebody has to go into a room where the patient is in isolation. And one organization said, why don't we just bundle the delivery of medications and food at the same time? A very simple intervention that limited the number of times somebody had to go into the room and maximize the use of protective personal equipment. We also looked at IV pumps. Why does a nurse have to go into the room constantly if we have electronic pumps that could be put outside the room with appropriate extension tubing? And also, how do we take advantage of recleaning the masks, because the poor supply that we've had around the world, and ensuring that everybody is safe and has masks that work and are effective. Why were these things possible? Well, they were possible because leaders facilitated that to happen. That leaders who had built a foundation of trust and commitment with all staff at all levels of the organization, that is, had built a culture where individuals were able to take advantage of the lessons learned, that they were able to be trusted to be able to do the work, that went ahead and did the work. It wasn't definitions, or it wasn't processes, procedures that were set up by somebody in an office and sent down to the people at the front line and told, you have to do the work. They encouraged the people who do the work daily to take advantage of the lessons that they had and the fact that they knew best how to manage some of their problems, and the leaders gave them that opportunity to do that. They also didn't just tell people, do it this way. They provided for them the training and the tools to improve. Oftentimes our interventions are, we'll write a policy, we'll do more training, we'll tell people to be more vigilant. All of those things are necessary, but they're not sufficient, because in order to actually have a process that works, we need to have the people who do the work to be able to come up and show us how to do it and find ways to do it. We use a method called a model for improvement, where you are allowed to do small tests of change to learn rather quickly, because sometimes you have a great idea, but once you test it, you find out that the idea does not work. We'll hear some examples today of how other organizations have taken advantage of listening to the people at the front line to be able to change how work is done. At any time that we are together, we have extremes in behaviors. We have those desired behaviors that people have, and then we have those disruptive, undesired behaviors. And that's a balance that happens always in life. And sometimes we straddle both sides, and sometimes we are all more on one side. But in a time of crisis, what happens is these things get exaggerated. That is, they become more severe, that those who have desired behaviors are more diligent and want to ensure that we're all doing the right thing. And those who are disruptive because of stress, anxiety, uncertainty, will act more so in an undesired manner. It is during this time of crisis that we have to step up and we have to deal with those undesired behaviors. A colleague of mine who is a chief quality officer at a hospital shared that at his hospital, those who shared the desired behaviors became less tolerant of the undesired behaviors and actually were very forceful in either helping the person change those behaviors or letting that person go because they just didn't fit and they were not helping the organization move ahead. Why is this discussion of culture important? Well, culture shows us the values and the behaviors that exist in an organization. That is, we can put up signs that say we're a safe culture, we can pretend we all act in a certain way, but really when you dig more deeply and examine the culture, you can learn what is behavior as desired versus behavior as it's actually accomplished. These are the two balances that we need to do, because leaders will often say, well, we have this great desire, people are all psychologically safe. In reality, though, if you visit the wards and you talk to the staff, you find that there isn't psychological safety. And that culture, you can better determine and better understand and surface those issues. However, we've also learned the importance of having a positive culture of safety. That is, in many studies now, we have been able to link the culture with the results. That is, the better the culture, that is the desired culture, I should say, the better the results. This is an older study, one of the first that proved that. This is by Brian Sexton, who showed that in Michigan, those intensive care units that had high levels of teamwork and a strong safety culture had gone the longest amount of time without a central line infection. Those who had a poorer culture, that is at the other end, a culture that did not support safety, are organizations that had shorter periods of time without a central line infections, meaning patients were more likely to get a central line infection in those units than they were where there was a strong culture of safety. So why is culture so important? Well, starting about 20 years ago or so, even a little bit longer, we started learning from other high-risk industries how they examined culture and the impact that it had, because we always have great technical solutions, but we don't take into account the behaviors and the culture that's necessary to sustain those technical solutions. We looked at things like the space shuttles in the United States, where we had 2 tragic disasters. We've looked at oil refineries, we've looked at oil platforms, we've looked at aircraft carriers, we've looked at nuclear power. And in each one of those, the investigations have been able to identify the weaknesses in the culture that existed that led to those disasters. Where a culture might have started strong at one point, the culture shifted because priorities shifted, and no longer were they holding each other accountable and acting in ways that supported their values and their culture. In the shuttle disaster, for example, the search for expediency gave up the concern that they've always had about the safety of the astronauts. And as a result, the space shuttle was lost and the number of lives lost. Also, looking at culture, we were able to better understand as we visited organizations whether or not they were acting in ways that were providing the appropriate care for patients. What were their attitudes? What were their behaviors? What are the things that they did on a daily basis that reinforced what they were doing? And over 20 years, we've also learned that there are a number of tools to measure that culture. And tools are necessary to measure culture because you need an indicator of what that culture means. But just measuring culture is not going to change it. What's necessary is taking that information and interpreting it, visiting the areas that show strong culture, the desired culture, and those areas that show a weaker or the undesired culture that you have. At the Institute for Healthcare Improvement, we've been studying this, as I said, for some time. And one of the elements that truly becomes important is to say, we're not here to change your national culture or your corporate culture. What we're here to do is to change the culture of where you work. The work, the respect, the time that you spend together is so critical for patient care. That is what we want to change. We are not intending to change your national culture. It is what it is. However, that culture will influence the workplace culture. And that is where the challenge comes up, because we have to take that into account as we ask you to act differently, as we ask you to do things differently. All of that becomes extremely important in our work. We've developed this framework. It's called the Framework for Safe, Reliable, and Effective Care. It is designed based on the work that we've had over a number of years with a number of organizations, as well as with over 3,000 people who have attended our Patient Safety Executive Development Program. And we built this as an opportunity for organizations to think through how to build their safety initiatives. As you can see, the framework has two domains. One is culture and one is learning system. And within each of those domains are a number of elements that support the culture and learning system. At the very center of our circle is patients and families and staff, because it's important that we take that into account. Not only do we want to make care safer for our patients, but we also want to make it easier and safer for our staff, especially in this time of COVID. The overlapping area is leadership, and we'll talk about each of these elements. But I want to point out that although this circle is represented as puzzle pieces and it is a circle, it is only a graphic representation. In reality, the work that we need to do to build a culture is each of these elements. Take, for example, the quality of the fabric of the clothes that you are wearing. That quality only comes from the strength of the threads, the quality of those threads, and how well they are woven together. That is an example of what it means to develop a culture of safety, that each of these elements must be strong, and how they're woven together is what makes a strong culture. Surrounding all that is trust, because without trust, we can't do any of the work. Many of the organizations that we've examined started by building trust amongst leaders, trust between leaders and staff and leaders, and all of that trust with patients becomes essential. Without that, you cannot have psychological safety, you cannot build that culture of safety, and you cannot develop a learning system that allows you to learn continuously what you could do better and what you are doing well now that you could learn from as well. Let's go through each of the elements. The first one is leadership, and leaderships are behaviors. This is what leaders do. They provide leadership. When we talk about leaders, we talk about leaders at all levels of the organization. That is not the ones at the just at the very top, but we talk about leaders at the top, we talk about managers, we talk about clinical leaders, we talk about people who are providing care, who are leaders. We talk about people who have influence but don't have the title of leaders. Their responsibility is to ensure that we are building that culture of safety, as well as to ensure that we have a strong learning system, that when things go wrong, we learn quickly, that we have improvement methods to be able to fix things, that our processes are reliable, that is, they are in the support of evidence-based care, and that we have transparency. Leaders are responsible for building psychological safety. They are responsible for ensuring that we hold each other accountable to our work and hold themselves accountable, of course. And they are responsible for fostering an area where we have teamwork and good communication. And they're also responsible for us negotiating, and I'll explain what that means. Psychological safety is the next element. Psychological safety is the ability to speak up when you see something wrong, the ability to ask questions, the ability to share your ideas and not feel that you're going to be put down. Basically, it's respect. It's treat people with respect, listen to what they have to say, and be able to respond to it. Psychological safety is essential for good teamwork, is essential for learning, is essential for people to manage situations. In this time of crisis, psychological safety is especially important because we oftentimes are facing situations that we've never faced before. And if we can't safely ask questions or safely step up and say, I think this may hurt the patient, then the chances are that patients are going to be harmed. And we need to have that psychological safety to prevent that. The next element is accountability. In the English language, accountability actually has a very negative connotation because we're going to hold you accountable. What we really mean is responsibility. That is, that you are held responsible to do the things that you're supposed to be doing. You've been taught how to do them, and you are doing them. The best example I have of responsibility is hand hygiene. That is, why is it that after so many years of trying to raise the rate of hand hygiene around the world, we still have difficulty? We know that we should be practicing hand hygiene. We know the techniques of good hand hygiene. Yet why is it that we have such difficulty in completing that? Yet if we hold each other accountable, then when we notice one of our colleagues is not practicing good hand hygiene, and it doesn't matter who you are in an organization, that you are able to speak up. I use an example that happened to me in Scotland, where the chief executive of the hospital and I walked into the intensive care unit, where they had very strict guidelines around naked from the elbow down, no rings, no watches, no ties, and we were violating every one of those. And as we walked in the door, the nurse at the door stopped us and said, "You can't come in. You are not following our practices here in this intensive care unit." When I looked at her and I said, "But this is your chief executive," the nurse responded, "It's not my problem. If you want to come to the ICU, you have to follow our practices." And the chief executive did just the right thing by commending that person and saying, "Thank you, and I will follow your rules." Teamwork and communication is essential because we are now at a time where all of the care we provide is provided as a team. So we have to respect each other. We have to be able to communicate. We have to use tools like situation, background, assessment, recommendation, SBAR. We have to use briefings, debriefings, huddles. And all of those become especially important during a crisis because the situation is constantly shifting, constantly changing. But we can't have good teamwork unless we have psychological safety. And we can't have good communication unless we have a psychological safety. And good teamwork requires responsibility and holding each other accountable. And likewise, you don't have accountability unless people feel safe and you are part of a team. So you can see how all of these are interwoven with each other. The last element we call negotiations. And by negotiations, I mean that we negotiate constantly. Every day in our lives, we have to negotiate for something, whether it be how to cross the street or whether it be the negotiations around food selection. Everything is basically a negotiation. But here, what we're saying is, if you are a doctor, a nurse, a pharmacist, other allied health professionals, you're a leader of an organization, that when it comes to patient care, your stand around the care that the patient should get is not based on who you are or what you represent, but what is best for the patient. So how can two doctors who don't agree on patient care, or how can a nurse and a doctor, or a pharmacist and doctor or nurse come together to resolve a conflict if they can't negotiate in the best interest of the patient? If we always put the patient at the center of the work that we are doing, it becomes a lot easier for us to come to find an answer for what we want to do. How does your journey start? Well, the journey is long. I'm going to tell you it's not an easy thing to change culture. It does take time. It does take a foundation of trust, as I said, and it does take understanding what you have today. Because if you are going to change something, you need to understand what the challenges are today, but also what the great opportunities that exist out in your organization. Second, you need to understand that to change culture, it begins with you. Look in the mirror. What are the behaviors that you exhibit that foster the values that you have in your organization that in turn support developing the culture that you want to have? You have to develop that trust amongst each other, with leaders, with staff, with patients, that they trust that you are there to provide the best for them and that you trust them to be able to be part of that decision process. You have to behave in the ways that not only build that culture, but then sustain it. Because if you spent a lot of time building the trust, it takes one wrong behavior, one disruptive behavior that can easily begin eroding that trust and that culture that you've developed. It becomes critical to maintain that and hold each other accountable to those actions. And then when someone acts in a way that does not support the values of the organization, does not support your culture of safety, that person is called out, again, in a respectful way. Our intention is not to embarrass anybody. Our intention is always to alert someone when they're not behaving in the way that we would like them to behave. There have been organizations that have been tackling the COVID crisis, and some have been more successful than others. And in this report from the International Journal for Quality in Healthcare, they give an example of 4 things that organizations have done successfully. They've strengthened their systems, looking at readiness, gathering evidence, all in the service of what was done pre-crisis. Because you don't just do this in the middle of a crisis, you prepare for it. You prepare for a crisis every day, that of what's going to happen. Engage with citizens and patients, because citizens and patients also have a certain responsibility to ensure their own safety. And how do we work with them to be part of our process and what we're trying to establish? Reduce harm for both COVID and non-COVID patients, because there are still those patients who need care. who still have chronic diseases that must be dealt with, who still have a crisis that is not COVID related. And how do we ensure their safety? And again, the safety of the staff. And ultimately, look for ways to collect lessons learned. What have you learned? And quickly see whether or not that becomes the new way of doing work. We know organizations that used to take months to make changes in what they needed to do, and suddenly they were able to do that in a day. Why is it they were able to move so quickly in that case, whereas in other times it takes forever to make decisions? All essential elements to not only continue with your culture of safety, but to respond to the crisis that we're all facing today. If you are interested in more information around the framework for safe, quality, and effective care, I ask you to visit the IHI website at ihi.org and download the free paper. It is free for you to use, and I thank you for your time. And as you hear the other sessions today, you will see how other organizations have had the opportunity to take advantage of the culture that they develop in order to manage this crisis. Ashley?
Wonderful, Frank. Thank you so much. And lots of good examples in there and lots of lessons, both for the immediate term around COVID, but also longer term about how we can support our organizations. So thank you for that presentation. Just a reminder to people that they can post the questions in the Q&A button at the bottom. So please, if you've got questions for Frank, please pop them in there. I've been having a look at the chat as we've been going through and looking at discussions from people. And there's been a lot of discussion, Frank, around the challenges that people face, whether they're in India or elsewhere, that organizations are quite rigid. There's a lot of other pressures, and to change patient safety is an uphill struggle. It's kind of pushing against the resistance there. So do you have any tips about how people can help their organizations move to that sort of patient safety culture?
Sure. So a couple of ideas that we've been working on and experimenting and learning is that we have made patient safety a project. And patient safety is not a project. Patient safety is what we do every day. That is, when we talk about taking care of a central line, it's not that as a project, it's how do you do that appropriately. When you talk about caring for a patient on a ventilator, it's what's the right way to do it. We call it patient safety, but I like to say it's the right way to do it. So patient safety is not a project, it's what you do every day. The other element is, yes, we do believe that there are many other priorities that organizations face. However, if you think of quality as a whole, that if you want to have safe care, you also need to be efficient and effective and timely and patient-centered. So all of those elements, if you bring them together in order to improve any one, if you improve it without thinking of all the other elements of the domain of quality, then you are doing yourself a disservice. We could provide safe antibiotic administration, but if it's the wrong antibiotic, have we done our job? Or if we've created that much more work in order to be able to administer the antibiotic, have we done our job? It's the fact that we have taken safety and we need to pay attention to it, but we need to fold it back into our daily activities because it is part of what we need to do every day. Also, as I said earlier, understanding the culture that you have is very important because change is difficult. And when you are asking people to change their behaviors, it's really a major problem. We can change behaviors. We can't change personalities. You are who you are. But let's be clear that when you are at the workplace, there are certain expectations of how we should behave. And if we all hold each other accountable to that, I think we'll reach our endpoint.
Great, thank you, Frank. And you mentioned throughout your talk the importance of all the different types of disciplines and professions to get involved in patient safety. And we saw at the start of today's presentation that we've got people here who are, senior leaders. We've got a lot of students involved as well. And for those students involved in medicine or nursing or other professions, what advice do you have for them to get started in patient safety?
So there are many things. One is that as we look at the workforce, coming into the workforce, the students who are now growing up, you are growing up in a different culture already. You are already thinking differently about work. I think about my own sons who have grown up and what they learned in school and how they behaved in school. And we'd like you to continue some of those positive behaviors that you bring into the workforce. We also want you to be able to feel free, that psychological safety, to question when you see something and understand, does that really fit what we're trying to do here? And I think that give and take between the existing workforce and the coming in workforce is really important. Most importantly, I think that the workforce that's coming in needs to understand, as I said, safety is what you do every day. This isn't a special project. Learn how to do things correctly the first time for patients, and you will provide safe care. but also learn to work as a team. You are a team effort. You cannot do it unless you do it together. And respect each of the disciplines, because each of them brings something new, something informative to the patient care that you may not know, and that's why you were a team, so that together, healthcare is very complex and complicated, and we need to work on it as a team.
Great, and building on that, Frank, we've just had a couple of questions, which we'll take one of those now, but how do we then go on to assess, and how do we measure the indicators described as culture, like leadership or psychological safety? So how do we measure that culture within an organization?
So actually, there are a number of tools that have been developed that are socio-technically tested. They are, for example, AHRQ in the United States has a very long survey that looks at culture, and it is freely available. There are other tools that have been developed by other organizations. When you think about psychological safety, Amy Edmondson has developed a 6-item checklist to ask about psychological safety. I oftentimes go into an organization and without having those survey tools, will ask a simple question. If you have an idea of something that you know you can improve, what happens to that idea? Where does it go? Or if you have a conflict with a colleague, how do you resolve that conflict? And just those questions, and again, you don't want to use the term psychological safety. You feel psychologically safe, because people don't quite understand what that means. But if you ask them a question about how behaviors are, you can quickly determine these folks are on the right direction for culture and these folks aren't. So although measurement using a tool is important, I think observation is also very important. I visited one intensive care unit where you could tell that the physician leader did not care about teamwork. The way he ran the multidisciplinary team, the questions that he asked clearly showed he was in charge and nobody was going to challenge him. Whereas we went to another ICU, intensive care unit, where the entire experience of multidisciplinary rounds was so different based on the way it was managed and handled. And those two things told me there's clearly one ICU has a culture that is being led to where they want to be, and there's another intensive care unit that really needs some help in changing that culture.
Great, that's very helpful, Frank, because I think measurement is one of the things we always find challenging in patient safety culture. So thank you for those helpful hints. I want to thank everybody for their questions coming into the Q&A box. We're going to probably have to move on just to make sure we get through the other presentations today. But I think, Frank, you're able to hang around a little bit and maybe answer some of those questions in the Q&A box. So please do keep those coming for Frank. And Frank, thank you again. Really great to have you with us this afternoon.
Ashley, thank you, and thank you to all of our participants.
Wonderful, thank you, Frank. So we're going to move on now to the next stage of our presentations today. I'm really pleased that next we've got some case studies, some short videos from experts on how their organizations have worked to preserve a culture of safety during COVID. So I'm really pleased that we've got Namita Jaggi, who's Chairperson for the Lab Services Infection Control and Chief of Education and Research at Artemis Hospitals, and Abdul Ghafur, who's Consultant and Adjunct Professor in Infectious Disease at Apollo Hospital. So they very kindly produced 2 short videos for us, which we're going to watch now. And then we've got some time for question afterwards. So please, I know you're still posting questions for Frank, but also please put your questions in for Namita and Abdul. And we'll watch your videos, and afterwards we'll come back for a bit of a conversation with both of them. So we'll see you shortly. Maddie.
Good evening, good afternoon, and good morning to friends and colleagues attending this virtual workshop all across the globe. I am Dr. Namita Jaggi, Chairperson for the Labs and Infection Prevention and Control at Artemis Hospital, Gurgaon, India. This is a 400-bedded, multi-speciality, tertiary care, state-of-the-art hospital located in Gurgaon. It commenced operations in 2007 and is now a force to reckon with, being one of the premier hospitals in Delhi NCR. It is a pleasure to be here at this virtual workshop of the International Forum of Safety and Quality in Healthcare, and I thank the organizers for giving me this opportunity to share my views and experiences with you. We've all been living through very challenging times of the COVID-19 pandemic for the past 6 months. The healthcare community, both in India and globally, have risen to the occasion and have gone above and beyond their duty to help mankind. We have lost about 3,000 healthcare workers globally and about 130 to about 150 in India. We appreciate their sacrifice and acknowledge their contribution and pay a tribute to them. The Indian government has also been very proactive in its endeavors, constantly releasing guidelines on its website, the Ministry of Health and Family Welfare and the Indian Council of Medical Research, designing, building and designating COVID hospitals, COVID care centers and quarantine centers, setting up the testing laboratories all across India, funding for the vaccine development, making available the drugs, and also putting very innovative apps like the Arogya Setu app, which is a contact tracing, and the self-assessment app, and the RT-PCR app, through which all the cases flow into the ICMR portal. In the next couple of minutes, I am going to take you through a journey of what as a hospital we did in these last 6 months, how we tackled this pandemic. What were the challenges that we faced, how we overcame them, what lessons we learned, and from those lessons, what strategies did we make and implement for infection prevention and control and safety so that we could emerge with an even stronger culture of safety. So let's talk about the challenges first. WHO China office first issued an alert on 31st of December 2019 that they were having an unusually large number of viral pneumonia cases. Subsequently, on January 9th, they called it the novel coronavirus. Between this time and 30th of January 2020, when we had our first case in India, we had made all policies, protocols, guidelines, implemented them, given the training, and we were fully prepared. We had also done a mock drill, but we did not know what challenges awaited us. As the pandemic progressed, the first challenge that came was that there was a bombardment of information. There was constantly changing and evolving guidelines hurled at us from all organizations across the globe, be it the CDC or WHO or our own Ministry of Health and Family Welfare and ICMR. The goalpost kept shifting. There was information given to us even through journals and WhatsApp groups. To add to our woes, there was now understanding that our enemy was hidden and silent, and that asymptomatic carriers could also spread the infection. So our policies of hand hygiene, masking, social distancing, and cleaning of high-touch surfaces had to be universal for all healthcare workers at all times. So not only did we have to keep our policies concordant with the changing and evolving guidelines which were being released from all across the globe, we had to keep training and retraining our staff. Which brings me to the next challenge, our staff. Our doctors, our nurses, our paramedics, technical staff, housekeeping, and even our general duty assistants. They were scared, they were exposed, they were overworked, not only in the hospital, but also with household burdens, as during lockdown, the kids had to stay at home. We had to not only keep them safe, we had to keep them happy, motivated, and invested into this work. And we achieved this. The third challenge arose with the shortage of PPE and supply chain issues. We had to look very carefully at the appropriateness of the personal protective equipment usage and also to explore whether we could reuse the PPE, especially the N95 mask. Initially, our management had decided to have an off-site center for the treatment of COVID patients. But with the governmental guidelines and mandate coming in that we had to have a number of beds dedicated to the COVID, we had to quickly make the COVID ward. And that was a challenge for us. The infrastructure, the infection control policies, the training of staff, rapid triage, rapid identification, and rapid isolation of the patients. And all this cost a lot of money, which brought us to the last but not the least challenge of balancing our revenues with the cost. The revenues dropped as lesser patients came into the hospital, the elective surgeries were deferred, and medical tourism dropped. And the costs escalated because we had to provide for the infrastructure and the resources. But we had to overcome these challenges and emerge stronger. And this we did with the help of our very strong leadership support. Our CEO and top management gave us a certain direction. We delegated and divided the responsibilities. We had very good teamwork. We introduced certain smart, cost-effective measures and even utilized technology for managing the patients better. We had 3 aims, and these 3 aims will stay with us in future as well to emerge with a stronger culture of safety. 1. To limit the introduction of COVID-19 into our facilities through patients, healthcare workers or visitors. Second, to limit the transmission of COVID-19 within our facility, that is rapid triage, rapid identification and rapid isolation of patients. And 3, to make our hospital a safe place for the patients and the healthcare workers to be in so that they don't catch an infection. Now I'm going to show you through some pictorial slides about how we actually manage this. To achieve our very first aim to limit the introduction of COVID-19 into our facility, we had 2 separate entrances, one for the visitors and asymptomatic patients and one for the patients who were suffering from cough, fever or breathlessness, that is COVID-like symptoms. They were thermally screened and screened through a questionnaire, social distancing was practiced and hand hygiene and masking. Visiting hours were suspended. The visitors were in general discouraged, especially the high-risk visitors and visiting the high-risk patients, and in general they were educated as well by means of banners, boards and standees or by training by the infection control nurses. Educational brochures were distributed like hand hygiene, the droplet precautions, contact precautions or the airborne precautions. For the management of the outpatients, we restricted the patient visit to the hospital. And how did we do that? By offering them alternatives like an online consult through our Artemis app. We had a helpline, we had home collection facilities. We also had an Artemis home isolation and treatment care package for the patients who developed mild COVID symptoms, where complete hand-holding was done by the hospital for the patients who were isolated at home in terms of providing them a care kit, 24/7 access to dedicated care doctor, issuing them guidelines, home delivery, and complete complimentary ambulance services as well. How did we manage the second aim, that is the rapid triage, rapid identification, and rapid isolation? This is our facility, which shows the place where the people who are suffering from symptoms come in. We had a negative pressure isolation room here. They were screened. The sample was collected in the isolation room. They were held in a holding area and then transferred to the suspected area by being masked. We had physical barriers and complete PPE for the staff who was working here. This area was cleaned twice daily with 1% hypochlorite, and we expanded the hours of operation to decrease crowding. This schematic diagram shows the zoning of the hospital. The green area is the non-COVID area, the orange area is the suspected COVID area, the red is the confirmed, and the yellow is the pre-operative patients. We had 2 entrances, as I have already explained. The main entry allowed the entrance to the visitors and the asymptomatic patients, and here also we practiced the 4 pillars of hand hygiene, social distancing, masking, and respiratory etiquette. We had this yellow area, which was the fever clinic, where the patients came in and their sample was collected. If they were having very mild symptoms, they were sent home for home isolation. After their sample was collected, if they had to be admitted, they were taken via a dedicated lift either to the suspected area or, if they were already confirmed, to the red area. There was no intermixing of patients from either of these areas into each other. Each area had a ward and an ICU. The pre-operative patients came into the hospital 1 day earlier. If they had to have an emergency surgery, regardless of their positivity, we had to do the surgery. But if we could defer the surgery, we would do it if they were positive. The COVID areas had a complete negative pressure isolation room. We had PPE used by the doctors and the staff at all times. It was cleaned regularly. There was a donning area, doffing area, and the biomedical waste was segregated and labeled as COVID-19 and then transported separately to the treatment facility. The third aim, how did we ensure healthcare worker safety? I have already discussed how we made the hospital a safe zone by cleaning, disinfection, safe work practices, and also modifications to the operation theatre and ICU. What did we do for the personal safety of their healthcare workers? We provided them personal protective equipment and trained them. Hand hygiene was practiced. We staggered staff to minimize exposure. There was a risk exposure assessment and a quarantine policy. We had a testing policy, prophylaxis, training and awareness, psychologist support, and in case they had to be admitted to the hospital, they had insurance. These were the numerous trainings online and on-the-job trainings provided, of course, with adequate social distancing to all the strata of the healthcare workers by the infection control nurses. Lots of mails were sent to the staff to educate them and make them aware of the latest happenings in the COVID-19 pandemic. We even conducted a mock drill. This was our COVID action plan, and the infection prevention and control guidelines were followed all across the hospital. Thank you very much, and we are all geared up for the battle. Together, let's fight COVID. I am sure in the coming months we will keep on learning from each other and emerge stronger than ever before with a very strong culture of safety.
Good morning. COVID is one of the biggest challenges the world has ever faced. Even a secondary school student can now understand the healthcare and even the financial implications of this virus. Let us rewind our memory to the pre-COVID era, where all human beings lived happily in their own ways. In the pre-COVID era, and that was just 7 months ago, to be precise, until the end of 2019. In the pre-COVID era, the biggest challenge the global healthcare field faced was the superbug crisis, otherwise called as the antimicrobial resistance crisis, the AMR. Hundreds of thousands of patients across the world have been dying due to untreatable bacterial infections. Bacterial infections where most antibiotics, or in many cases no antibiotics, work. The global economy is expected to lose $100 trillion by 2050 as a result of the superbug crisis. Experts, organizations, and governments were convinced on the importance of tackling this menace on a wartime footing. Though most countries initiated national plans to tackle the challenge, the progress at global level is highly inadequate and pathetic. What's the reason behind this lethargy? Drug-resistant superbugs wage their war on humans in a hidden and silent manner. And then, out of nowhere, the COVID appeared on the arena and started monopolizing the thought process and actions of humanity. COVID has become the super killer. The world forgot about the deadly bacterial superbugs and the killing spree these microbes unleashed. COVID attacked humans in a dramatic way. Politicians and policymakers were quick to launch counter-attack on COVID. There is no doubt COVID is a supervirus. What we need to realize is the COVID supervirus and the bacterial superbugs are partners in an organized crime. These two grandmasters in the microbial world are co-conspirators in their war against humans. More than 70% of hospitalized COVID patients receive antibiotics. 10 to 20% of hospitalized COVID patients develop bacterial infections. 30% of the COVID patients in the intensive care units had bacterial infections. More than 50% of the COVID patients who died also had secondary bacterial infections. More data is now emerging from various countries. Many of these bacterial secondary infections were due to superbugs. We have now learned that a supervirus like COVID initiates the massacre, while bacterial superbugs make the final kill in many COVID patients. They are partners in crime. We should not forget our non-COVID patients. As usual, bacterial superbugs are still killing hundreds of thousands of other patients. All the infections and diseases that existed in the pre-COVID era still exist. Bugs are trying to confuse us, misguiding us to follow the wrong strategies. 1 teaspoon of soil contains a greater number of bacteria than the number of humans in the world. Bugs are interconnected like a vast internet network. They talk to one another. They conspire and even laugh at the helpless and pompous humanity. We knew we had to follow infection prevention measures in our hospitals, but we neglected this entity. We knew we have to wash our hands to get rid of superbugs, but we refused to wash our hands. We knew we had to keep our surroundings clean. Instead, we ruined our environment. We carried superbugs across the world. Now microbes made us ground our global network of airlines. We knew we needed new antibiotics, antivirals and vaccines. Industry thought these molecules would not bring them enough profit. We were busy manufacturing plenty of anti-diabetics and anti-cholesterol drugs. And now the world is frantically experimenting our old hydroxychloroquine and ivermectin. COVID is a wake-up call. We have learned our lesson. Now we are keeping on washing our hands. We have learned to keep our surroundings clean. We are desperately developing drugs and vaccines, but still we are misusing antibiotics. COVID is Mother Nature's messenger in devil's uniform. If COVID hasn't taught us to use antibiotics wisely, are we expecting another messenger? Do we need the sun to crash into the earth? Thank you.
So Namita, Abdul, thank you so much for making these videos. It's really nice to see those practical examples of how organizations and individuals have experienced the last period during the COVID pandemic. So thank you again. Hopefully you can both join us on screen and we'll take some questions. We've had a couple of questions through in the Q&A box, so please keep those coming. I'm going to start by one challenge that we've all faced, I think, no matter what country you're in, what organization you're in, what individual you are. We faced a challenge that COVID, we've been bombarded with information. We've been bombarded with, guidance from governments, from WHO, from lots of papers that have been published and even retracted in some cases as well. I'd love to ask you both, Namita, from your experience, how do you help to communicate to staff, and how do you kind of give them that knowledge, that patient safety knowledge of what is your approach as an organization, and any advice you'd have for other people in the same situation?
Okay, so with Abdul's permission, I'll go first. You very rightly said we were bombarded with information, and by hastily written papers and journals and WhatsApp groups, and I think we were really busy as a community trying to absorb all that information, sift through that information, and take out the relevant information. So we had to really up our training and communication with the staff. We did it at various levels and in various forms. We not only gave them print information through emails, we had a lot of webinars for them, we had even on-the-job trainings with social distancing, and we maintained not so many, but some WhatsApp groups where we really solved the problems of the staff. And we had an open sort of a WhatsApp group in which anybody could pose a question. I also do realize that it was a problem for our own infection prevention and control team in the hospital. So we had a constant communication with the infection prevention and control team throughout the day, what they were doing, what problems they were facing, because they were our field soldiers, the nurses, and we were managing them from a center. So I think by employing various methods of communication, we did it. And I think communication and training can really never be enough. It was always learning and then relearning and then applying those measures and then checking whether those measures were working and then again going about it. So, we did that. The other thing which we did was that we had to continuously change our processes based on the information. We had to change our guidelines quickly, and then we had to change our processes and then retrain the staff. So that's how I think we managed it.
Brilliant, thank you. Abdul, you maybe want to pop your video on, but anything you want to add to that?
Yeah, COVID was actually a test on the integrity of modern medicine, because over a span of 6 months, we changed our beliefs significantly. We thought we don't have to mask, and now masking is compulsory. And a few months ago, we did not know anything about COVID. Now we know a lot about COVID. And we knew journals retracting important articles. So we saw a lot of things in 6 months, and we don't know what we are going to learn in the coming few months.
Great, thank you. So thank you for all the questions coming in. Lots of, I think, clinical questions, which hopefully we can get you guys to answer afterwards. One question that's sort of come up that we've touched on in Frank's discussion as well is around the sort of stresses and strains on our staff. So we've got all our staff now working very hard, in patient safety and managing COVID, creating, lots of resilience issues as well. And I'd love to hear from both of you around, what do you think is important for supporting staff with resilience, avoiding burnout, getting through what's a tough time where we're all working a lot more than usual in very difficult circumstances with, PPE, which is very constrictive and what we're not used to. So Abdul, do you want to go first?
Yeah, we all know that healthcare workers have been working very hard over the last few months, and healthcare workers are under stress. The most important aspect of convincing healthcare workers is communication. From the management side, from the colleague side, from the doctors, nurses, all of them have to communicate each other. You talk to the doctors and nurses in the COVID ward constantly, cheering them up, encouraging them. It changes the mood. And talking to the patient, it's not just the healthcare workers. You just take around in the COVID ward. The patients are not able to see the face of the doctors, the face of the nurses. So talk to them more often, talk to the healthcare workers, and talk to the patient. Communication is the key in pandemic.
Lots of good advice. Thank you, Abdul. And Namita, any thoughts from your side?
Yeah, I do agree with Abdul, and just like he said, communication and training is important. And I'd also like to add that leadership, the key over here was the leadership. And just like Frank said, leaders at all levels, and the formal leaders who had a designation, and then also the informal leaders who were kind of the influencers. So, the leadership really had a big role to keep the team together. And they did it in various ways, to motivate the staff. Now, different things motivate different people. So you really had to know your team. What motivates your team? What motivates one person? It could be recognition. It could be just the feeling that they were doing something important, larger than their cause, in contributing to this pandemic. So that was one thing. It was having the right cultural fit. So hiring was really on a freeze during this time. But, if you were to hire somebody, it had to be the right cultural fit. It had to be resolving the conflicts, the interpersonal conflicts, which had really become more at this time because everybody was stressed. And it was also trying to avoid attrition by being a good role model. And then, developing that trust, just like Frank was saying, looking after their psychological safety. And the most important thing, which not the least, is really, looking at your second in command, succession planning. So planning for the next time, looking at your successors, and really keeping the team together. And then that team could work wonders, because once your team is happy and motivated and you are a leader, you had to really walk the talk at this time. So you really had to be there out in the field with them, work with them, and kind of keep motivating them all the time.
Thank you. And I think it's wonderful to hear all these examples, because I think there's never been a situation in healthcare before where we've been in such an unprecedented time. So I think we're all going through this together to work out how we manage the staff, the resilience, the information as well. So really helpful to hear your examples. And again, please everyone, please do share your examples and thoughts and ideas in the chat box as we go through. I want to thank you both. In the interest of time, we're going to move on, but there's still a couple of questions there, Namita and Abdul, that we'd really appreciate if you could go through and answer those in the chat box to the people who've asked those, maybe specific about your organizations. But thank you both for producing the videos and being with us today. So really, really appreciate it. So thank you.
Thank you. Thank you.
Thank you.
So next up, we've got a great friend of the International Forum, Dr. Ravindran, who's chairman of Aravind Eye Care System in India. As many of you know, Aravind is a global example of quality and safety, both in eye care, but also just inspiring general patient safety work across organizations. So it's a real pleasure to have Dr. Ravindran here today. This session is really exploring that overview of patient safety work undertaken more generally, but also as part of COVID-19, as part of the pandemic as well. So really great to have you here. Again, please post your questions in the Q&A box, and we'll take those very shortly after this presentation. So Dr. Ravindran, over to you.
Yeah, thank you. Thanks for this opportunity to present about the patient safety and quality of care in Aravind hospitals, especially during this period when we have this COVID pandemic. I mean, when we talk about safety and quality, it's all about how do we build an organization. It's about what is the right perspective we have about these elements when we deliver the patient care. And in a larger sense, it's also about defining the boundaries of what we do and whom we serve. I mean, this aspiration of Dr. J. Venkataswamy, who founded the Aravind Eye Hospital way back in 1976, is about eliminating needless blindness, which has been his lifelong work, by providing high quality eye care to all. So when you want to provide services to everyone in the community, when you want to ensure equity in healthcare, the challenge is how do you create access for the eye care or healthcare, and how do we make it affordable and at the same time give the best of the quality and safety to the patients. And keeping in mind the question of access, which is very important, which also determines the affordability part of it, Dr. V went on to create almost about 14 tertiary and secondary eye care centers. We also have about 6 outpatient clinics. Dr. V also realized the difficulties of the people in the rural area to access eye care, and that's the reason why he started this eye camp even during his stint in the government eye care system. And today we run about 2,500 eye camps annually, in addition to about 79 primary eye care centers in the villages, through which we care for about nearly 2,500 patients through a video conferencing system. As a result, during the pre-pandemic era, and at least until about the 24th of March, we were seeing anywhere between 14,000 to 15,000 outpatients, and we were providing surgery for nearly about 1,700 people. And ensuring the safety and the quality is very important when you have the volumes are very high, and especially nearly 60% of your patients are provided free care or subsidized care who come from the rural areas. And in the quality framework, all of you are familiar with, which has been promoted by the Institute of Medicine with 6 aims of quality, talking about safety, patient-centered care, efficiency and effectiveness, about our first speaker spoke about, and also the timeliness and equity, is probably the basis on which we have built our quality and the safety network. And especially we have put a lot of focus on building the patient safety, which is about not harming the patient. And until maybe 2010-11, I can say the concept of patient safety was more in the realm of unconscious level. So we brought it to the consciousness of all our staff. We had organized several workshops since then. We started off with how safe is our hospital, openly sharing what goes wrong in each of our hospital, how errors happen, and we try to make the staff understand that the whole safety process is related to the work process. Initially, we started off with the JCA patient safety goals, which is built on communication, patient identification. But we found over a period of time that our staff were not really able to relate to that. So we really redefined the patient safety goals. Just for the convenience, we put them as 10 goals. So this, with which our staff was really able to connect with, and that gave a lot of clarity on what we meant by patient safety. And based on that, whatever we said, we sensitized all our staff about the never events which happen in the system. We put in place a very robust identification system for the patients, including the barcoded wristbands. We also put in place surgical site marking, following checklists, timeout in the OT. All this kind of became a kind of a routine about 10 years back. We also put in place a root cause analysis and resetting of the protocol. And we also brought in a culture of reporting. Initially, we had a paper record when not many things were reported, but once we moved on to the electronic form and people were able to report anywhere anonymously, we were able to have a large number. The hospital where I'm kind of stationed in Madurai, we anywhere get about 900 to 1,000 reports, even though the number of sentinel events are less than or in single digit. So in addition, we also have a system of constant monitoring and redesigning, especially for continuous improvement. We have weekly meeting across all our hospitals, which looks at surgical complication, our biometric results, which looks at whether our IOL power calculation, the IOLs we have placed in our patient's eye are all correct, and we also look at the safety incidents and the infection control at periodical intervals. Just to give you an example, in order to ensure correct eye anesthesia, which is a common problem we face, about 4 or 5 incidents of giving anesthesia in the wrong eye were reported earlier. And we moved on to not only marking the forehead of the eye over the eye, but we also did the double marking. So which helped to reduce the incident, but it never went away. But this is about behavior. The first speaker also talked about changing the behavior is difficult, but when we brought in a system wherein a paramedical staff or a nurse stood along with the doctor for eye confirmation and patient confirmation, this problem was kind of solved. So some of these things, unless we really bring in system, it's very difficult to ensure safety across the system. When you're working with about 5,000 staff, systems are very important in addition to having good staff. I also would like to share with you our surgical infection rate. Earlier, if you look at 2010-11, we used to have about anywhere between 8 to 10 patients have surgical infections out of 10,000, which is like 0.08%. We put a lot of effort in improving our infrastructure, sterilization process, and we were able to bring it to maybe like 0.07 or 0.06, as you can see in the year 2013-14. But the time when we introduced intracameral antibiotic, amoxifloxacin of about 500 microgram, our surgical infection rate dropped to about 0.01 or 1 per 10,000. And we had recently published about 2 million cataract surgeries, wherein we had about 1 million cases with the drug and 1 million without the drug, and we were able to show that every year we were able to prevent 200 more eyes from developing endophthalmitis. Today we may have about 70 or 80 patients. Earlier, this could easily, for the volume, for earlier infection rate, could have been much more. And now it has been taken up by a lot of surgeons across the world. And again, we also have a Aravind Cataract Quality Assurance Registry, wherein all these surgical steps of the cataract surgery and also the outcomes, including the complications, are entered. And once the patients complete their follow-up, a report is sent to the doctor. The doctor will be able to have a brief review of their complication rates and the visual outcome rates. And they also can benchmark themselves with the other doctors who do a similar kind of a volume. And as a result, we are now able to even look at benchmark ourselves with what happens in other countries. And this helps us to kind of set a benchmark going forward each year. And each doctor can benchmark themselves, each hospital can do it, and as a system, we also can try to improve the whole outcomes. To kind of summarize what we have done in the pre-COVID era, we have identified areas where the safety errors happen. We have tried to understand how they happen and develop the protocols. And we have done everything to reduce the complexity and create independent checks. And again, monitoring this, sharing this with the appropriate people and redefining the process have really helped all along. And coming to this COVID-19 pandemic in the state of Tamil Nadu, where most of our facilities are located, we are probably the second largest state numbers in India, and we have somewhere about 230 patients. We do about 60,000 plus tests every day, and the daily numbers touch about 7,000. So we have been in some kind of a lockdown since 24th March of this year, almost for the last 5 months, and recently today they said it will be extended by another month. So during this period, we really understood the protecting our staff and also the patients is very important during this period. And what we found that, we realized that more than the patient, the staff safety is very, very important. Without the staff safety, we may not be able to either build this patient safety or the patient centeredness. So we have put a lot of effort to understand how this coronavirus transmission happens through literature and also talking to the experts. And we really understood the importance of a close contact with the patient. Ensuring that we have to really screen the whole system. Today, we probably even in Madurai during this lockdown period, we get about 600 to 700 outpatients come for the care. But screening all of them becomes important, which includes thermal screening, a proper triaging. We also are able to get the history through a structured form and also a consent. And once we identify those people with any kind of risk factor like a fever or anything, we isolate them. And we don't ask them to go away, but we see them in a select separate area near the triaging, and we are able to see these patients. And also patients who have conjunctivitis, which is supposed to be one of the feature of early COVID. All these patients are isolated and seen in a separate area with the proper protective equipment for the staff. And similarly, like the patient, the staff screening is also very important. We request the staff who are not well to stay at home. And those who come, we do a regular thermal screening. We provide them with appropriate PPE. We make sure that even the staff do a practice social distancing. And personally, we request all of them to avoid attending any personal family social gathering as well. And we have developed, even within the organization, we have a manufacturing facility called Orolab. We have used it to produce the face shields. We have asked them to make decontamination units, and we have developed a system so that we'll be able to reuse this PPE on a regular basis. So we have put in place the protocols necessary. And for all the employees, we have done an employee risk assessment based on the Welsh protocol. And we also initiated a detailed examination of all the people above the 40 years to rule out any undetected NCD. Like this hospital where we have about 1,000 staff, maybe like about 15-20% are above the age of 40 years. We had about 14 new diabetics were detected. And whoever have diabetes and hypertension, we ensured that they were taking their drugs regularly and the whole problem is under control. And for those who come for the work, we had a kind of a daily health monitoring. One senior employee is allocated about 10 or 12 staff. Her job or that person's job is to make sure that that she goes through the checklist and make sure that they are well. And a lot of awareness talks, training have been done. A lot of psychological. We had psychologists and psychiatrists talk to our staff to improve their self-confidence. We formed a COVID task force who take care of any of these incidents. We also have nearly about 2,500 staff stay and trainees stay in our indoor, hostel facilities. So taking care of them is very important. So we have put in place isolation and quarantine facilities as well. And we have made sure that every space within the hospital is well ventilated, including our basement. Whatever required, all the changes have been made. Like in the operating room, we have put in place, all the AHUs have been modified to have the UV lamps. And whatever protocol that has to be done in the operating room were all taken care. And again, we have developed a checklist for the disinfection for each clinic, every area, and people have been made responsible for all of that. All this we have done just to ensure the safety of our staff and also the patient and the other visitors who come into the organization. At this point of time, equally important is how do we build the patient trust. So as you can see, the outpatient numbers have dropped across the system, across our all fixed facilities by about 75%. The surgeries have dropped by about 85%. So this is the period. Patients are not able to come because of the vehicle movement and also out of fear as well. And it's very important that we continue to provide the care. So we have a good number of patients to start with who needed care, continuity of care, because they had a surgery or an injection or a laser. So we had took out all their case records, and each ophthalmology was assigned maybe like 25, 30 records to all these patients. The doctor will initiate the call, talk to them, and give them the necessary instruction. If required, we also have initiated WhatsApp video calls. And equally, we used to get about 500, 600 phone calls from the patient asking for whether about care and how they can reach us. And whatever we were able to support them to the telephone, we did it. And we also had put in place a video consulting system by that time. Each hospital was given about 3 portals wherein they'll be able to talk to the patient. And they were all redirected to those portals, and the doctor was able to talk to them. The patients were able to take some photograph and show them or upload them into the system, and we were able to do that. And this has helped a large number of the patients. When the patients came, we had put in place awareness posters, we had given them brochures and the videos so that they really understood the changed protocols. And again, at the same time, we made sure that the comprehensive examination is given to the patient. We did not compromise on that part at all. And at the same time, we tried to maintain all the values, which is about being accessible. We did not change the clinic timings or hospital timings. We remained affordable and also provided the compassionate care. And we also knew, today we are seeing only maybe like 25% of the volume, but as time, once they lift the lockdown, the number of patients are going to go up, but we won't be able to do it in the same way we did earlier. So we have to adopt to the new normal. So we have been planning for the future as well. How do we efficiently manage the patient flow? So as an organization, we are only used to walk-in patients. No patients have got an appointment. Everybody comes on the days they prefer to come, but we still provided the care and also surgery. So in order to address this, we have put in place a patient scheduling system, mainly to stagger the patient volume. So when we looked at estimated the hourly capacity, and based on the capacity of the staff we had, we were able to see that, to our surprise, we were able to see that if we are able to stagger them, we'll be able to see at least 90% of what we see on a daily basis. So based on that, we have put in place a scheduling system which the patient can do either in person coming over to the hospital or over the phone call. The second strategy we have put in place is how do we minimize the cross referrals within the organization. It happens either from a general comprehensive unit to a specialty, or from one specialty to specialty, or from a primary or secondary care centers to the base hospitals. So we are trying to see what kind of infrastructure we can develop within these centers, and also what kind of a training we can give so that these cross referrals or referrals can be minimized. And each department has developed a criteria for the patients who need referral and the patients which can be managed by the general ophthalmologist. The third part we are trying to work on is how do we minimize the follow-up visits. So completing the care process at the same time so that the patients don't have to come again. So whatever investigation or even a treatment like a laser or an injection, whether we can do it at the same time, we are doing our best to create systems for that. And we also have revisited our follow-up protocol so that we can stagger the follow-up visits. We are also moving towards promoting telemedicine for the follow-up visits, which will be decided at the time of final examination when a patient comes into the clinic. At the time of disposal, whether this patient can benefit just from a telephone or video consultation, or whether he needs to come here in person, that is also being finalized. So we have given enough provisions in the EMR so that this can be operationalized going forward. And again, we are also seeing how we can improve the teamwork across the system and also the EMR, so that the overall time taken for the examination, which is now like 2 hours for nearly about 80% of the patients who come for a comprehensive exam, and the 3 hours of specialty, how it can be reduced by adding additional stations, additional manpower, so that we'll be able to efficiently see them. So all these things are happening right now so that when the volume picks up, we'll be able to take care of them. So to summarize, the patient care goal during this period is mainly about ensuring patient safety. Only if you're able to put in place the measures for the patient, the staff safety, we will be able to have the patient's trust. And we are also trying to create all the To make this transition, we have formed internal teams for each, right from procuring that PPE, disinfecting, patient care, the staff roster, all that, the different teams have been created. And we have had probably, I've never been so busy in the last 10 years. The last 3 months have been really busy time for all the leaders and the chief medical officers to ensure that we give the best of the patient care. And we have tried our best to understand the principles of the patient care in this changed area. We have tried to involve as many staff as possible and create the awareness across the system. And this is the period, it's all about sustaining the organization growth. It's the testing period, as many of the speakers said. How do we maintain the community's trust and faith, and how do we continue to build the trust in our services? It can happen only through our quality of services, maintaining that empathy and compassion, being transparent in our processes, ensuring equity. I mean, still all our free hospitals run, all our free services, in spite of all the financial difficulties, we still take care of all the free patients who come to us. And it's also about humility, which helps us to remain as a learning organization. Thank you.
Dr. Ravindran, thank you so much. It's always highly educational when we hear you speak, and thank you also for picking up on the challenges you faced during COVID. It's really helpful to hear how you've addressed those. So thank everybody for the questions. We've had a number of questions coming through on the chat box. The first one I want to ask is, you mentioned about your COVID task force. And one of the questions we had in was around the role of the quality and safety team within your hospital. And what role have the quality and safety team played as part of that task force, or more broadly within the COVID response?
When we talk about this COVID task force, it's about making sure somebody is not well. Now we have this health monitoring tool, daily monitoring tool. If a staff is not well, what are we going to do with that? If a staff reports somebody in their house has tested positive or has got a fever, what we are going to respond? When somebody really turned positive within the organization on testing, how are we going to do the contact tracing? And as I said, we have nearly over 2,500 staff trainees stay in our hostels. So we have to create the isolation facilities, quarantine facilities, making sure that we have enough staff to care for them. So all this is also the role of this COVID task force. And we have the chief medical officer probably as the head of this, and others will report to them. So we really involved all the senior people into taking care of this. So earlier, all the frontline workers who were managing the reception, inquiry, were all kind of a junior staff. But today, they are the senior most staff stand there to take care of the whole the thing, because we feel that's the most important thing.
And of the quality and safety team, you've got a really great quality and safety team, and it's sort of well renowned for leading the way. What's the role of the quality and safety team during the COVID time?
To tell you frankly, we don't have any central quality team across in any of our hospitals. I mean, it's all entrusted to every department. Every department is responsible for their own quality and safety. We have not created anything, a central team. So sometimes I struggle. I'm kind of director for the quality, but I help in certain place a process, but I don't really have a team which will monitor and say. I mean, we kind of hand it over to the chief medical officer, the head of the department, to monitor. And we have some regular meetings we conduct. We make sure that complication meetings are run. We make sure that the accreditation done on time. We make sure that infection control meetings all happen. But today, we have not really involved that team to be part of this COVID task force. The COVID task force, we have put all senior people who are kind of empowered people in the organization, who will be able to make the decision on their own without asking somebody.
Great, thank you for that. And it's great you've got the structures in place. One of the things we touched on earlier was the frontline staff, the resilience, the burnout, the challenges that COVID's presenting for them as far as dealing with very different circumstances. Staff wearing PPE, working around the clock, shortage of beds. How are you finding frontline staff dealing with COVID with regards to culture and resilience? And is it improving? Do you think things are going to become more challenging over the next 6 months? What's your thoughts on that, Dr. Ravindran?
See, we have been really preparing the month of, say, March. Even before it started, we had several meetings with our Chinese colleagues. A lot of our doctors, we have trained a lot of ophthalmologists in China. So even before the lockdown, we had meetings with them and really understood what we need to do. But it was like 2 or 3 months of preparation. And today we are facing the challenges. Today with the community spread, we know our staff's family get infected. Okay, I mean that is kind of psychologically upset some of the staff, and we are able to sense that. And we had some senior psychologists, psychiatrists to talk to all our staff. We had some of our senior doctors give presentations on about this psychological strengthening, what it really means. We really try to put in place emphasis on the proper use of the PPE, and we keep telling them you're not going to get the infection in the hospital. What if you're going to get infected? It's going to happen in your house or in your social environment. So that's where you have to really practice all this. What we teach you in the hospital is what you have to. So we keep emphasizing that point again and again. Yeah.
Thank you. And this may be a little bit too early at this stage during the pandemic, but is there anything that you or Aravind's learnt out of the COVID? Is there a kind of key takeaway that might change how you work going forward, or is there a key takeaway that you think is really important for the quality and safety community to take forward after COVID?
So there's a lot of good things. We maybe also look at some of the practices we put in place, like hand washing, aseptic, disinfection protocols. All that we feel is very important. So whatever we want to preserve that. So as one of our speakers said, we were not able to change the behavior of hand washing, but now it has happened. But even the disinfection, we want to create a system. So we have put in place even kind of a unit for disinfection. We have even where that water will be stored, where the soap will be stored, where the solution, all that we have tried to make sure that it remains as a system even going forward, which we used to say earlier was not happening. Now it's also the time that how do we realize the importance of creating a system, creating the infrastructure so that it will stay on. Yeah.
Wonderful. Well, Dr. Ravindran, thank you for joining us. It's always great to have you here, and thank you for sharing all your thoughts, expertise, and advice during COVID. So thank you again.
Thank you. Yeah.
Wonderful. Well, I think that's almost us for today. This, as you know, was our first webinar. We've got a whole series coming up, so please do check the International Forum website to see future webinars and to keep up to date with our physical event. We still hope to bring the forum to India very, very soon, so please do stay up to date with the information. I want to thank you again for joining us. I want to thank you again for all the hard work that you have been doing to keep patients safe and work during the pandemic. So we look forward to seeing you soon. Thank you much for joining us, and please stay safe. So thank you.
Thank you. Thank you.